This is the Chapter 18 activity to help you learn the Chapter 18 material. So Part 1, hormones, too much or too little. In preparation for the following case studies, let's brainstorm what could happen if you had too much or too little of a certain type of hormone. This will help us review the hormones and their functions. So number 1, fill in the chart below. So if we start with aldosterone, the organ where it is produced is the adrenal cortex. Specifically, it is produced in the zona glomerulosa, which is the outer layer of the cortex. And before we talk about what would happen if you had too much or too little, let's remember what the function of aldosterone is. So aldosterone normally functions to cause retention of sodium ions and the excretion of potassium ions. So it keeps sodium in the body and it gets rid of potassium. So if you have too much aldosterone, it actually leads to a condition called hyperaldosteronism. And if you think about it, aldosterone causes retention of sodium and excretion of potassium. So too much aldosterone would cause too much loss of potassium. So you would end up with too few potassium ions, and that's a condition called hypokalemia. Conversely, you would keep too many sodium ions around, and that's a condition called hypernatremia, which is too many sodium ions. These are the Latin words for potassium and sodium, and so if you've ever wondered where the K and the Na comes from, they come from the Latin terms. So kalemia means potassium, and that's where the K comes from. Sodium is natremia, so Na comes from that. Because keeping too many sodium ions in the body would also cause the body to retain a lot of water and fluid, you would also get water retention, which could lead to high blood pressure, which is known as hypertension. Too little aldosterone would cause hypoaldosteronism, and this is basically the opposite. So I don't have enough aldosterone, so I'm not getting rid of enough potassium, so I end up with hyperkalemia, too much potassium. I'm also not retaining enough sodium, so I end up with hyponatremia, which is too few sodium ions. And because I have hyponatremia, I'm likely to have a lot of fluid loss as well. So I'll have a loss of fluid, which could lead to low blood pressure, which is also known as hypotension. And these are not necessarily details that you need to memorize for an exam. This is just to help you think about what would happen if a hormone didn't function like it should. So it kind of helps you learn the functions. These terms, though, hypokalemia, hyperkalemia, hypo, and hypernatremia, they are going to come up later in the semester when we get to chapter 27. So if you want to go ahead and learn them now, it'll help you later. Thyroxine is also known as T4, and this is one of the thyroid hormones. This is the most abundant of the two thyroid hormones. So there's T3 and T4, and most of our thyroid hormones that are circulating in our body are of the T4 variety. These are produced in the thyroid gland, specifically the follicle cells. And again, before we talk about what happens with too much or too little, let's review the function of thyroxine. And the normal function is to regulate metabolism. And so thyroxine regulates the production of ATP by mitochondria in all of our cells, and that determines our basal metabolic rate. So if we have too much thyroxine, this could lead to hyperthyroidism. So you've got too much of this metabolic hormone, so you're going to have a ramped up metabolic rate. So an elevated metabolic rate, and this will lead to things like weight loss, increased perspiration because your muscles are making more ATP, so you've got a higher body temperature, hand tremors, difficulty sleeping, fast heartbeat, and diarrhea. And again, all of these can boil down to the elevated metabolic rate. If you don't have enough thyroxine, that can cause hypothyroidism, and this is the opposite. You would have a lowered metabolic rate, so your metabolism is much slower, so you would gain weight. You wouldn't be making as much heat, so you would have an increased sensitivity to cold. You might feel cold all the time. It can lead to depression. You always feel tired. You can have a slow heartbeat, and you can end up with constipation. And again, these all boil down to having the lowered metabolic rate. And then I just want to point out two very common thyroid disorders that you may hear about. And I'm also pointing these out because a few of these terms are in your clinical terms for this chapter. So Graves' disease is a type of hyperthyroidism, and this is caused when your body starts producing antibodies that actually attach to the thyroid and stimulate it. So the antibodies cause the thyroid to produce excess thyroid hormone. That's why it leads to hyperthyroidism. One of the main characteristics of Graves' disease is bulging eyes, and that's one of your clinical terms. It's called exophthalmos. And then you also end up getting a goiter, and that's because the thyroid is being constantly stimulated. And whenever the thyroid is stimulated, whether it's by TSH or in this case antibodies, it causes it to enlarge. So here are the common symptoms of Graves' disease. Again, the bulging eyes is one of the unique characteristics of this disease. Most of the rest of the symptoms other than goiter also occur in people who just have hyperthyroidism. The opposite of this, another different type of autoimmune disorder, is called Hashimoto disease. In this case, you get hypothyroidism because the immune system actually attacks and destroys the thyroid gland. You still end up with a goiter because without the thyroid gland, you're not making any T4, which doesn't go back and turn off the TSH production at the pituitary. So you end up with elevated levels of TSH, which cause whatever is left of the thyroid gland to enlarge. So Hashimoto's disease, basically all of the symptoms of this are going to be the same symptoms you get with hypothyroidism. It's just an autoimmune disorder that causes hypothyroidism. All right, so moving on to insulin. Insulin is produced in the pancreas, specifically by the beta cells. And again, before we look at too much or too little, let's talk about the function of insulin. Insulin functions to lower blood glucose levels back to normal when they rise. So typically after you eat, your blood glucose levels rise up and insulin is secreted to lower them back down. So if you have too much insulin, it's going to lower your blood sugar levels too much and cause a condition called hypoglycemia. That means low sugar. So hypoglycemia is low blood sugar. It can actually lead to very dangerously low blood sugar levels. And this results in confusion and tiredness because your brain's not getting enough energy. It can also lead to sweating and shakiness. You might have felt this one time if you were very, very hungry. Sometimes we have like what's called sugar crashes after you've eaten a lot of sugar, and you might get a little bit of hypoglycemic and you start just feeling a little bit shaky and you're like, oh, my blood sugar is low. So that's that feeling. However, having too much insulin typically isn't a natural problem. So the pancreas doesn't ever produce too much insulin, but what can happen is that diabetics who give themselves insulin injections can accidentally inject too much insulin. And this is a very dangerous condition because when the brain goes too long without glucose, coma and then death can occur. So there actually are a number of cases of people who have died from accidental insulin overdose who are diabetic and give themselves insulin injections. So what happens if you have too little insulin? Well, that's going to lead to hyperglycemia or high blood sugar levels, and this is the condition we call diabetes mellitus. So remember, there's a type 1 and type 2. Type 1 is if you can't make insulin, and type 2 is if your cells aren't responding to the insulin, which would be the same as not having any insulin. So one of the hallmarks is this leads to an increased thirst, increased urination. You also have frequent hunger because basically all of your cells are starving because the sugar is trapped in the blood and they can't come into the cells. So you're constantly getting the signal that you need to eat. And then everything that we talked about in the lecture concerning all of the potential side effects of diabetes mellitus would be applicable here as well. So parathyroid hormone is produced by the parathyroid gland, and specifically the parathyroid cells in the parathyroid gland. And the normal function of parathyroid hormone is to raise blood calcium levels back to normal when they drop. So remember, parachuters drop out of planes, so parathyroid hormone is released when calcium levels drop. So its goal is to raise the levels back to normal. So if you have too much parathyroid hormone, you're going to raise the calcium levels too high, and you're going to end up with hypercalcemia. Hypercalcemia could lead to brittle bones and even osteoporosis, and this is because parathyroid hormone is telling the bones to release the calcium. Part of the way that it raises blood calcium levels is by stealing the calcium from the skeleton and putting it in the blood. So if you have consistently high parathyroid hormone levels, you're going to take so much calcium away from the skeleton that you're going to end up with brittle bones and osteoporosis. You also can end up with kidney stones from the extra calcium in the body fluids, and you can end up with constipation. Conversely, if you don't have enough parathyroid hormone, again, remember, its function is to raise blood calcium levels. So if you don't have enough of this, your calcium levels are going to stay too low, which is called hypocalcemia. And this can result in cramping and twitching muscles and tingles and numbness. This is due to deficits in muscle and nerve functions, because if you remember from last semester, muscles and nerves really need calcium to do their jobs. And if the hypocalcemia gets low enough, it can cause seizures from the neurons not being able to work properly. And then we come to cortisol. So cortisol is a type of glucocorticoid. It is produced in the adrenal cortex, and specifically in the zona fasciculata, which is that middle layer. Now, cortisol actually has a lot of specific functions. It can do a lot. It actually can go into the nucleus and change the regulation of like up to 300 different genes. So cortisol has a lot of different functions. We can kind of sum up a lot of what it does by saying that it helps to mobilize energy stores to prepare to handle stress. But if you remember, it can also suppress reproductive function. It can suppress immune system function. It can cause high blood sugar levels because it's actually causing the glycogen to be broken down into glucose, but it's also causing your cells to use fatty acids as an energy source, so you end up with more glucose in the blood. So cortisol has a lot of different functions that centers around our stress response. And the reason I included cortisol on this chart was because you are going to talk about too much or too little cortisol in your lab course, so I wanted to go over that here as well. So too much cortisol actually leads to a condition called Cushing's syndrome, and this can cause rapid weight gain and abdominal obesity. Because of the rapid weight gain, you can end up with a very round face. It's a characteristic look called a moon face. You can get fat pads on your neck and shoulders, sometimes called buffalo humps. You can get excessive sweating, and you can develop what's called the metabolic syndrome, which is a triad of symptoms that include insulin resistance and hyperglycemia, hypertension, which is high blood pressure, and obesity. And so notice that with the rapid weight gain and the obesity, it typically occurs in the abdominal area, so the legs and arms can still appear skinny, while you end up with a lot of fat just around the middle. Now, Cushing's syndrome actually is of note for those of you going into the healthcare field, because there's a lot of people who take steroids for different inflammatory conditions. For example, asthmatics and people with arthritis and people with other chronic inflammatory conditions may take steroids as prescription medications, and prescription steroids can cause Cushing's syndrome. Because when you take a prescription steroid, you're essentially taking a chemical that is the same as cortisol. So all of these symptoms here can be caused by prolonged use of steroid medications. So it is important to be aware of the Cushing syndrome symptoms. So if you have too little cortisol, this can cause a condition called Addison's disease. This is much less common because this would actually require that you have something wrong with your adrenal cortex. If too little cortisol can cause things like fatigue, weight loss, reduced appetite, increased sensitivity to cold, hypoglycemia, which is low blood sugar, low blood pressure, and interestingly, you can end up with hyperpigmentation, which is a darker skin color, and that's because without the cortisol around to turn off the ACTH production in the pituitary, then you have more ACTH around, and it seems that for some reason having more ACTH will actually stimulate the melanocyte stimulating hormone, so you end up with that particular hormone released as well, which can darken your skin color. So here's a little image. I got this actually from a study site to help nurses prepare for their nursing exam. And so it just compares the different symptoms between Cushing's syndrome and Addison's disease. So Cushing's syndrome is going to end up with a lot of body fat around the trunk and the head and the face, whereas with Addison's disease, they may end up being very skinny. Notice you've got the hyperpigmentation, so the darker skin over here. You've got the weight loss. And then with Cushing's syndrome, this is that moon face I was talking about. You can also get those little fat pads, the fat deposits on the face and the back of the shoulders, and you may end up also seeing a lot of bruises and stretch marks because of the rapid weight gain, and it also makes your skin very thin, and you can more easily bruise and damage your skin. So anyway, that was just a little bit of background on 2 of the diseases related to cortisol. All right, so now let's move on to the case studies. So this is part 2, which is a case study called Mary Keeper's Aching Head. This morning at 4 a.m., Mary Keeper woke up with yet another throbbing headache and decided she couldn't stand it anymore. She needed to see a physician. She took some Tylenol and then spent the rest of the morning lying on her couch until the physician's office opened that morning. During the initial examination by the physician, the following observations were made. The pulse was slightly elevated, 95 beats per minute. Patient had slightly low blood pressure in the office, 95/65, but reports dizziness when standing. Patient's skin was warm and moist. Patient appeared fatigued. Patient reports lack of sleep due to recurring headaches. Patient has lost 10 pounds since her last appointment 10 months ago. Patient reports no loss of appetite. Patient has a slight hand tremor. Patient reports more frequent bowel movements. So number 1, brainstorm possible endocrine deficiencies that Mary may have. Use the chart you made in part 1 to help you. So there's no really right or wrong answer to this question. The purpose of this question was to have you compare Mary's list of symptoms with the chart that was made back in part 1. So some observations that you may have made include the following. Her elevated pulse fits with hyperthyroidism, so a fast heartbeat would give you an elevated pulse. Her hypotension, low blood pressure, fits with hypoaldosteronism and Addison's disease. Warm, moist skin could be indicative of increased perspiration, which fits hyperthyroidism and Cushing's syndrome. Fatigue and headache could match any number of disorders. Those are very common symptoms. Weight loss fits with hyperthyroidism and Addison's disease. Hand tremor fits with hyperthyroidism. More frequent bowel movements could fit with hyperthyroidism or Addison's disease. More frequent bowel movements usually also means diarrhea, because the faster that stuff moves through the colon, the less water gets reabsorbed, which we'll talk about in chapter 24. So number 2, after a couple of days, Mary's blood work results come in. On her results, there were asterisks by the T3 and T4 values, both of them being very high above the normal limits. Does this support your conclusion from question 1? If not, would you have a new suggestion for Mary's problem given these results? Are any of Mary's symptoms not explained by your suggestion? So, given Mary's very high T3 and T4 levels, she has hyperthyroidism. So you may have noticed from the previous question that several of her symptoms did match with hyperthyroidism. Hyperthyroidism causes increased perspiration, fast heart rate, hand tremors, anxiety, difficulty sleeping, thinning of the skin, fine brittle hair, muscular weakness, and more frequent bowel movements, aka diarrhea, and weight loss may also occur without a change in appetite. Mary's headache and low blood pressure, hypotension, are not really explained by a diagnosis of hyperthyroidism. Number 3. Mary's lab results also showed lower than normal TSH levels. Explain why TSH levels would be low when T3 and T4 levels are high. So first, let's recall the signals that result in the production of T3 and T4. The hypothalamus secretes thyrotropin-releasing hormone. Thyrotropin-releasing hormone tells the anterior pituitary to secrete thyroid-stimulating hormone. Thyroid-stimulating hormone tells the thyroid to secrete T3 and T4. Now we need to also think about negative feedback. Once T3 and T4 are produced, they work in a negative feedback loop to turn off the production of TRH by the hypothalamus and TSH by the pituitary. So since Mary had excess T3 and T4, remember her T3 and T4 levels were very high, these hormones are keeping the production of TSH turned off through negative feedback, resulting in her having low TSH levels. Number 4. Interestingly, Mary's blood work also showed lower than normal ACTH and GH levels, but normal CRH levels. How could this be explained? Does this provide a reason why Mary is having headaches and low blood pressure? So, adrenocorticotropic hormone and growth hormone are both hormones produced by the anterior pituitary gland. Corticotropic releasing hormone is produced by the hypothalamus, and it is a signal to the anterior pituitary to produce and release ACTH. So if her CRH levels are normal, but her ACTH levels are low, then that suggests a problem with the anterior pituitary gland. So it's not responding to the signal from the hypothalamus telling it to release ACTH. So something being wrong with the anterior pituitary gland would also explain having low growth hormone levels. Pituitary tumors can cause frequent headaches either by compressing the third ventricle and causing a buildup of CSF, or by stretching the dura mater that surrounds the pituitary gland. A pituitary tumor that causes low ACTH could also lead to low cortisol levels, because remember, adrenocorticotropic hormone is the signal for the adrenal cortex to produce cortisol. And having low cortisol levels could explain her hypotension and all of those other symptoms that matched Addison's disease. So Mary likely has both hyperthyroidism and a pituitary tumor. And I like this case study because it reminds people going into the healthcare field that patients may not show up with just one thing wrong with them. So in this case, Mary went to the doctor because her headaches got so bad and she was tired of losing sleep from the headaches. They just happened to also find that she's got hyperthyroidism, and the real problem causing the headaches was actually a pituitary tumor. So she shows up and she's got all of these hyperthyroidism symptoms, and so she gets her hyperthyroidism diagnosed, but she also had another condition that was causing her headaches. Number 5, what is the function of thyroxine, T4? What is necessary for the production of thyroxine? Describe thyroxine production, storage, and release by the follicle cells of the thyroid gland using the picture provided below. So I'm making some room to put the answer here. So to answer the first question, thyroxine maintains a normal metabolic rate. Specifically, it targets mitochondria in the body cells to produce ATP. The second question on what is needed, iodine is required to produce thyroxine. And then now we're going to walk through the steps of the production, storage, and release using the little numbers that are on this image. So at number 1 down here, we're showing the follicle cell taking up iodide ions. The iodide ions are then converted to iodine, and then they are attached to a thyroglobulin protein to produce T3 and T4. The newly synthesized thyroglobin complex with the T3 and T4 inside of it is stored in the follicle cavity, and that's shown up here, number 3. So notice that number 3 is the cavity area. And then in response to TSH, the thyroglobulin complex is removed from storage and brought back into the follicle cell. Number 5, the thyroglobulin complex is broken down to release T3 and T4, and the excess amino acids are recycled to make more thyroglobulin. Number 6, the follicle cell releases T3 and T4 into the bloodstream. Number 7 shows that T3 and T4 in the blood can be either free or bound to transport proteins. The majority is bound to transport proteins, about 75%. Number 6, which cells in the body are targeted by T3 and T4? Even more specifically, where in the cell do these hormones act, and what is the ultimate outcome? So thyroid hormones target almost every cell in the body. Thyroid hormones are transported into the cell where they bind to receptors on the mitochondria and signal an increase in ATP production. Thyroid hormones can also affect the cell's gene expression, changing the cell's concentration of certain enzymes. So the ultimate result is an increase in a cell's metabolism and metabolic activities. Number 7, Mary's friend Tom has many symptoms that are opposite to Mary's symptoms. He has dry, scaly skin, fatigue, a low pulse rate, 60 beats per minute, constipation, weight gain, and hypothermia, meaning he's always cold. Tom's medical examination revealed low levels of T3 and T4 and elevated levels of TSH. When administered an injection of TSH, this did not increase the levels of T3 and T4. What could be Tom's problem? Would you expect to find a palpable goiter? Why or why not? So Tom has hypothyroidism due to a problem with the thyroid gland. So they injected the TSH to see if the problem actually was with the thyroid gland, and because the TSH did not increase the levels of T3 and T4, it can be concluded that the thyroid gland has the problem and is not functioning correctly. And yes, we would expect Tom to have a palpable goiter, so that means a goiter that can be easily felt by touching the neck area, and you may even be able to see it swelling out from the skin. So why does he have a goiter? Well, his thyroid hormone levels are low, so he's got very low T3 and T4. So there is no negative feedback to turn off the production of TSH by the anterior pituitary gland. And the constant high levels of TSH, notice that he had elevated levels of TSH, the constant high levels of TSH cause the thyroid to increase in size, resulting in a goiter. So it can increase in size even if it's not functioning to release T3 and T4. So a goiter is ultimately caused by a constant elevation of TSH. Part 3 is a short little case study called Eric and Sam, New A&P Study Partners. Eric and Sam met in their A&P class and decided to form a study partnership. They both had similar schedules and liked to study the material in similar ways. As the semester progresses, both Eric and Sam notice that they are becoming increasingly thirsty. They both start drinking much more water throughout the day, which also results in increased urination. Both men decide to go to the doctor, but first they use their A&P knowledge to brainstorm possible causes for these symptoms. Number 1. What are 2 possible endocrine dysfunctions that could be affecting Eric and Sam? What tests could be run to help distinguish between these 2 conditions? What endocrine organ is responsible for releasing the hormones that may be dysregulated? 2 possible endocrine disorders that could cause increased thirst and urination are diabetes insipidus and diabetes mellitus. Diabetes insipidus is caused by a lack of antidiuretic hormone, ADH, so the body cannot hold on to water or fluids. The hypothalamus is responsible for releasing ADH through the posterior pituitary gland. Diabetes mellitus is caused by a problem with insulin signaling, so blood glucose levels rise because the cells cannot take up the glucose from the blood. The beta cells of the pancreas are responsible for releasing insulin. A quick way to distinguish between these two types of diabetes is to test for glucose in the urine. Glucose present in the urine indicates the problem is diabetes mellitus, because this is the only time we see glucose in the urine. You could also do a blood test to test for blood sugar levels, but usually the urine test is faster, and in the old days they would actually just taste the urine. Diabetes mellitus, actually the mellitus part means sweet, because the urine would have a sweet taste, and insipidus is tasteless because the urine would be tasteless. Number 2, Sam is told that he has type 2 diabetes. How does this form of diabetes differ from type 1 diabetes? What are some dangers of untreated diabetes? So note that in all of these cases, we're actually talking about diabetes mellitus. So type 2 diabetes mellitus involves insulin resistance. The pancreas can still produce insulin, but the cells of the body are no longer responding normally to the insulin signal. So insulin resistance is linked to an unhealthy body weight and a sedentary lifestyle. In contrast, type 1 diabetes mellitus involves a lack of insulin because of damage to the beta cells of the pancreas. So to treat type 1, you only need to give an injection of insulin. To treat type 2, they may give you insulin injections, but also other medications, and they may have you lose weight and start an exercise program as well. The cells and tissues of a person with either type of diabetes mellitus are undergoing an energy crisis. They can't take up the glucose that is essentially stuck in the bloodstream, so the cells are starving for a source of energy for the mitochondria to use to make ATP. So left untreated, this energy crisis can eventually affect multiple organ systems across the body. So you can end up with diabetic retinopathy, or a type of blindness where the blood flow to the retina is compromised. You can end up with diabetic nephropathy, which is a problem with the kidneys. You can end up with early heart attacks due to the effects of the lack of energy in your cardiovascular system. You can have diabetic neuropathies from death of peripheral nerves, so like tingling in the hands and the feet, and also pain. And you can also have poor wound healing, and this is seen a lot in the feet because they're the farthest away from the heart, so they get the most compromised circulation first. And when these wounds remain untreated and unhealed, they can even lead to having to have foot or leg amputations. In part 4, we're going to look at homeostasis and other endocrine questions. So number 1, fill in the blanks below to describe calcium homeostasis in the body. So I'm going to put this little image up from your textbook as we walk through filling in these blanks. So first, we're going to start when blood calcium levels become elevated. So that means they're going above 11 milligrams per deciliter. The thyroid gland, and specifically the C cells, release the hormone calcitonin. This hormone inhibits osteoclasts, which causes calcium to remain deposited in the bone. And calcitonin causes the kidney to excrete calcium, meaning the kidney is putting the calcium from the blood into the urine. So urine would have higher calcium levels. Both of these actions will lower blood calcium levels. So now let's look at the flip side. And again, here's a picture we can look at. So now we're talking about if blood calcium levels become too low, so falling below 8.5 milligrams per deciliter. Now the parathyroid gland releases the hormone parathyroid hormone. This hormone stimulates osteoclasts, which causes calcium to be released from the bone. This hormone also causes the kidney to reabsorb calcium. So kidney is taking the calcium out of the urine and keeping it in the blood, so you would have decreased calcium loss in the urine. So this hormone also causes the kidney to reabsorb calcium and to secrete the hormone calcitriol. This second hormone, the calcitriol, causes increased absorption of calcium by the digestive system. All of these actions will result in the blood calcium levels rising back up to normal. So number 2, fill in the blanks below to describe glucose homeostasis in the body. And again, I'm going to throw up the picture from the textbook. So when blood glucose levels fall, and in this case they would fall below 70 milligrams per deciliter, the pancreas releases the hormone glucagon from the alpha cells. This hormone causes an increased breakdown of glycogen to glucose and an increased breakdown of fat to fatty acids. It also results in the synthesis of new glucose by the liver. So essentially, glucagon is resulting in more glucose being added to the blood, which will raise levels back up to normal. Then if we look at the flip side, when blood glucose levels rise, so if they go above 110 milligrams per deciliter, the pancreas releases the hormone insulin from the beta cells. This hormone causes cells to remove glucose from the blood, or you could have said take up glucose from the blood. It also causes excess glucose to be converted into glycogen for storage. It also increases glucose usage by cells, increases protein synthesis, and increases triglyceride synthesis. So basically, insulin is taking the glucose out of the blood and bringing it into cells for either use or storage. Number 3, Ellen is an avid sports player. She loves to work out in her spare time, and she plays on her college's soccer and basketball teams. Ellen notices that her periods are very irregular, and some months she doesn't even have a period. Explain why Ellen's menstrual cycle is dysregulated. Be sure to mention all of the relevant hormones. So as a very active athlete, Ellen probably has low body fat, meaning she's got very little adipose tissue in her body. Without sufficient adipose tissue, Ellen isn't producing much leptin. So leptin is a hormone produced by adipose tissue. Without normal leptin levels, the hypothalamus is not secreting gonadotropin-releasing hormone, or GnRH, as it should. Without normal GnRH levels, the anterior pituitary is not getting the signal to release normal amounts of follicle-stimulating hormone, FSH, and luteinizing hormone, LH. Without adequate levels of FSH, Ellen's ovaries won't secrete normal amounts of estrogen or develop follicles once a month. And without adequate levels of LH, Ellen's ovaries won't secrete normal amounts of progesterone or undergo ovulation. And later in the semester, when we get to chapter 28, we'll see exactly what the estrogen and progesterone are doing to regulate the menstrual cycle and ovulation. Number 4, you are working in a lab that helped to discover the new hormone X. X is a water-soluble hormone. Where would you look for receptors for this new hormone? What types of cells in the body would be affected by this new hormone? Describe a possible mechanism for how this hormone sends a signal to a cell and what effect or effects it could ultimately have on the cell. Think in general terms. So since X is a water-soluble hormone, it wouldn't be able to cross the plasma membrane of cells. Therefore, we would expect its receptor to be a plasma membrane protein on the outside of the cell. So if you're a scientist looking for a receptor for this new hormone, you would look in the membrane on the outside of the cell. Hormone X would affect any cell in the body that has a receptor for it. So this is just to drive home the point that cells can only respond to a hormone if they have a receptor for that hormone. So I took the picture that I used in the lecture and I modified it to show hormone X is now this blue triangle. So if we have a cell over here and it doesn't have any receptors for hormone X cannot affect it. However, these two cells on the right both have receptors for hormone X, so hormone X would be able to affect both of these cells. So when you're asked what types of cells would be affected, the answer would be any cell that has a receptor for that hormone. Now the second part, describe a possible mechanism. Since hormone X uses a plasma membrane receptor on the outside of the cell, the receptor is likely what we call a G protein coupled receptor, or GPCR, that is attached to a G protein. So here you can see the hormone outside the cell, the G protein coupled receptor in the membrane, and it's attached to a G protein. So when X binds to the receptor, it will initiate a cascade of reactions inside the cell using a second messenger. And the two most common second messengers are cyclic AMP or calcium ions. Cyclic GMP is often also frequently used, but these are the two most widely used. And then the final part of the question, what effect could it ultimately have? Think in general terms. Well, in general, hormones can have the following effects on a cell. They could alter the genetic activity of the cell by turning genes on or off. They could alter the rate of protein synthesis by changing rates of transcription or translation. Or they could change membrane permeability by inserting or removing carrier or channel proteins. Number 5. When you are stressing out about homework assignments and exams, you are activating the slower, longer-lasting stress pathway. Describe this pathway. Be specific about how the message travels from organ to organ. What are some implications for chronic stress or for having this pathway be continually activated? So the slower, longer-lasting stress pathway is called the HPA axis. The hypothalamus is going to start it off by releasing corticotropin-releasing hormone, or CRH, into the capillaries at the median eminence. The CRH will then travel through the hypophyseal portal vessels to the anterior pituitary gland. The CRH will signal the anterior pituitary gland to release adrenocorticotropic hormone, or ACTH, into the bloodstream through a second set of capillaries. Remember, portal systems are connecting two sets of capillaries. The ACTH will move through the bloodstream, where it will finally target the zona fasciculata of the adrenal gland cortex, which is the middle layer of the cortex, and it will stimulate it to release glucocorticoids, of which cortisol is the most common. Normally, cortisol works in a negative feedback loop to turn off CRH and ACTH, but this can become dysregulated in chronic stress conditions. So chronic stressors do keep the hypothalamic pituitary adrenocorticotropic axis going, or the HPA axis. This can result in increased levels of cortisol, which can increase appetite, anxiety, depression. It can activate various enzymes. It can cause deposition of visceral fat, which is like fat around your stomach. It can make you crave more fat and sugar in your diet, and it can decrease fat breakdown, all of which can lead to weight gain, which can lead to being overweight and obese. And chronic stress can also affect the body. It can affect the brain to make it difficult to concentrate, cause anxiety and depression, irritability, bad mood, mind fog. It can affect the cardiovascular system. It can result in higher cholesterol levels, high blood pressure, which all can increase your risk of heart attack and stroke. It can increase inflammation in your joints and muscles, muscle tension, aches and pains, muscle tightness. It can decrease your immune system function, lower your immune defenses, which will increase your risk of becoming ill or increase your recovery time if you do get sick. Your skin, it can cause hair loss, dull, brittle hair, brittle nails, dry skin, acne, and delayed tissue repair. In your gut, it can cause nutrient absorption, diarrhea, or constipation, indigestion, bloating, pain, and discomfort. It can also decrease your reproductive system hormone production, decrease your libido, and if you're a female, increase your PMS symptoms. So some common risks of chronic stress, if you can't remember all of this, remember these 6 little things. You can end up having trouble sleeping or feeling unrested. You can end up with a dysregulated nervous system and fatigue, anxiety, depression, and mood changes, high blood pressure, heart attack, and stroke, menstrual cycle changes and trouble conceiving, and weight gain or trouble losing weight. So if chronic stress is a problem in your life, and it seems to be a problem in a lot of people's lives, you can learn stress management techniques like meditation to help reduce your levels of stress. Laughter also reduces your cortisol levels, and as we mentioned in chapter 17, crying actually gets rid of some of the cortisol through your tears. And then I have one last little question. It's sort of a food for thought question. So why do you sometimes seem to wake up just a few minutes before your alarm clock goes off? Well, everyone has a normal diurnal rhythm of cortisol secretion. So when we wake up, so right before we wake up, our cortisol levels start to rise. They actually will peak 30 minutes after we wake up. Then they'll start to decrease throughout the day, and they'll be low again at bedtime or shortly thereafter. So cortisol levels are the highest 30 minutes after you wake up and the lowest at bedtime. The CAR is actually the cortisol awakening response, or CAR, and this is the term used for this increase in cortisol right at the time that you normally wake up. So it's thought to be your body's way of mobilizing the energy reserves and preparing to start the day. So if you follow a regular sleep-wake cycle, meaning you go to bed at reasonably the same time and wake up at reasonably the same time every day, then your body gets used to this cortisol circadian rhythm, and this can result in a natural awakening around the time that your alarm would normally go off. So this is why, if you get up at the same time every morning, you'll soon find yourself waking up at that time, even if you don't have an alarm. In my case, it's easy to fall back asleep. Note that this daily rhythm of cortisol is normal, and this is going to occur in people even if they have no stress. However, chronic stress, as we talked about in the previous section, can actually dysregulate this normal natural rhythm, which can cause issues of its own. And that is it for the Chapter 18 activity.